This is a primer on cognitive behavioral therapy for pediatric anxiety disorders. The objectives of this presentation are to differentiate clinical from non-clinical anxiety in children, recognize the core components of cognitive behavioral therapy or CBT, and provide an overview on a typical course of CBT and discuss treatment considerations. Please remember to call our BHIPP telephone consultation line for specific treatment-related questions. When discussing clinical versus non-clinical anxiety, it's important to remember that fear and anxiety can be adaptive. Consider the case if you saw this hungry tiger when you walked in a room, you would experience a strong fight or flight response and run in the other direction. In that instance, anxiety is adaptive and can help you avoid being eaten by this hungry tiger. In general, fear and anxiety are common and are natural responses to many situations, like seeing that hungry tiger. However, they're circumscribed to specific events. When seeking to determine the difference between clinical and non-clinical anxiety, it's important to inquire about the presence of anxiety along with its frequency, intensity, distress, interference, and duration of anxiety symptoms and anxious responses. When anxiety responses are frequent, intense, cause interference, and last longer than 6 months, an anxiety disorder may be warranted. Let's review common childhood anxiety disorders, each which has their own diagnostic criteria. There's separation anxiety and specific phobias that are often seen in early childhood, and as children develop through middle school and high school, social anxiety, generalized anxiety, and panic symptoms can emerge. There is also several anxiety-related conditions such as selective mutism, obsessive-compulsive disorder, and trauma or post-traumatic stress disorder. There are several screening tools that can be used in primary care to efficiently and effectively assess whether or not clinically significant anxiety is present. A common screening tool that is publicly available is a screen for child anxiety and related disorders, or SCARED. There are both parent and child-reported versions of this form. Scores above 25 typically correspond with clinically significant anxiety. When significant anxiety is identified on these scales or in your interactions with patients, it's important to refer out for a comprehensive psychological evaluation to determine whether or not your patient meets diagnostic criteria for one or more anxiety disorders. Typically, a psychological or psychiatric evaluation for anxiety will include a clinical interview that goes through all of the diagnostic criteria and assesses the origins for these symptoms. When significant anxiety or an anxiety disorder is identified, it's important to remember that there's two primary evidence-based treatments. One option is selective serotonin reuptake inhibitors, which has been covered in a previous BHIPP brief. The other is exposure-based cognitive behavioral therapy. Exposure-based cognitive behavioral therapy for pediatric anxiety is a structured approach to treatment in which children and parents learn skills to manage anxiety. It's demonstrated considerable efficacy in randomized clinical trials and has been shown to be an effective treatment in community practice. Although cognitive behavioral therapy, or CBT, is an efficacious treatment, many families and clinicians often question whether or not their child or patient is receiving CBT. Here we'll cover 5 common elements that are seen in most manualized CBT protocols. First, there's psychological or psychiatric education about child anxiety. In this part of treatment, patients and families learn about the cognitive behavioral model of anxiety and how thoughts and feelings and behaviors are all interrelated. This is a core part so that patients and families understand how the skills that they will learn in CBT will help them manage their anxiety. There's relaxation training skills that are often taught. These might include things like progressive muscle relaxation or diaphragmatic breathing to help reduce physiological or somatic symptoms of anxiety. Many individuals with anxiety also struggle with cognitive worries and have cognitive distortions in which they have anxious thoughts that make them believe that negative events are more likely to occur than they are in reality. The bulk of treatment is placed on behavioral experiments or exposures During exposures, patients and families learn to face their fears one step at a time, usually in a stepwise progression. And last but not least, as patients and families learn skills and practice facing their fears within treatment, they're assigned homework assignments to complete between sessions to continue to build skills outside of the therapy visit. There is considerable variability, but here we present a typical course of CBT. Typically, CBT will begin with psychoeducation about anxiety disorders so that patients and families understand the skills that they will learn, and also normalizes the experience of anxiety. Next, a clinician will often develop a symptom hierarchy to prioritize which symptoms are causing the greatest distress and impairment for families. This is also useful when engaging in treatment planning activities to identify symptoms that might be most manageable to target first. Over the next several visits, patients and families will learn either relaxation training skills to deal with somatic symptoms of anxiety, learn to challenge anxious and worrisome thoughts through cognitive strategies, and then begin to face their fears through exposures. Over the course of CBT, related skills can be incorporated into treatment as needed. These may include things such as social skills and problem-solving skills to manage situations in which anxiety can complicate things. A typical CBT session is highly structured. This is much different than other types of therapies that may be more open-ended. Typically, CBT sessions will occur on a weekly basis. The session will begin with a review of interlevel events and whether or not homework was completed, and discuss challenges with homework completion. Afterwards, the session will move on to present a new skill or technique to help the patient and family manage anxiety. This skill will be practiced in session, and corrective feedback will be applied as necessary. At the conclusion of the visit, homework will be assigned for each patient to build on the skill that was taught in session. It's important to remember in many cases caregivers will be involved. However, caregiver involvement needs to be developmentally appropriate. For a young child, caregivers will be much more involved in treatment in comparison to an older adolescent, in which caregivers may only be involved to ascertain information about homework completion and provide information on the upcoming week's homework assignment. Considerations when recommending CBT to family are important. The first and foremost is to consider whether or not a patient and family is ready to start CBT. Starting CBT requires considerable work and effort on the family in terms of finding a therapist, attending treatment sessions, and putting in the effort to complete homework assignments between therapy visits. In many cases, the anxiety may not be significant enough to warrant this effort and this commitment from patients and families. When recommending therapy to clients and patients, there's also some concern about prior therapy attempts. Oftentimes, patients and families will say, I've been in therapy for several months, or I've tried it before and never gotten any better, so why will it be different? This is where it's important to assess whether or not prior therapy trials were actually cognitive behavioral therapy, or whether it was more supportive therapy or art therapy or another type of therapy in which the evidence base is not necessarily as strong as it is for cognitive behavioral therapy. It's also important to note that not all therapists are the same, so there may not be the benefit that was previously obtained with a new therapist. Last but not least, it's important to consider access and availability of CBT providers. Although CBT is recommended as a first-line treatment for pediatric anxiety disorders, in many cases, the availability and accessibility of CBT providers may not be accessible to many patients and families. As a result, it may be patients and families may have long waits, have to drive considerable distances, and may be more inclined to seek medication management. A core piece related to anxiety is school refusal and avoidance. These are common problems that many children and adolescents face. While school avoidance and refusal can be related to anxiety, a comprehensive psychological or psychiatric assessment is needed to determine the cause. Otherwise, It's important to do this in order to tailor the skills to address the cause or concern that's driving the school avoidance and refusal. For instance, if a child has a fear related to performances at school, they might complete performance exposures. If they're worried about being embarrassed when they go to school or eating in the lunchroom, exposures can be tailored around facing fears related to embarrassment. Last but not least, if the fears are related to contamination and have more of an obsessive compulsive disorder presentation, contamination exposures can then subsequently help the patient reduce school avoidance and refusal. Let's briefly review whether or not. Let's take this question in consideration. An 11-year-old girl presents with her mother who reports that her daughter has a generalized anxiety disorder diagnosis. When you ask her about treatment, she describes that her daughter has been seeing someone for the past year. When you ask her mother to describe what goes on in treatment, which of the following sounds most like a CBT session? She usually goes into therapy by herself, and I don't know what they do in there. She gets to talk about her problems and sometimes feels better. She learns skills to deal with her anxiety and is assigned homework that I help her do at home. She sees a doctor once a month who talks to her for a bit. As you can see, the correct answer is C, because it focuses on skills, practice, and also mentions homework. In summary, anxiety is common in children and adolescents. When clinically significant anxiety is present, it's important to remind patients and families that there are at least 2 evidence-based treatments that are available to them. Exposure-based cognitive behavioral therapy is an efficacious and effective treatment for children and adolescents with anxiety disorders. In its structured format, patients and families learn to develop skills to manage and overcome anxiety in CBT. Thank you for watching this BHIPP brief. As a reminder, if you have general or case-specific questions about treating anxiety disorders, or for assistance identifying resources and referrals in your community, you can always call the Maryland BHIPP telephone consultation line. For more information about BHIPP services, can be found on the program website. Thank you for watching.